Welcome all of you to this live program with Orthopedic Principles. Today our guest of honor is Dr. Theodoros Bouras from Patras, Greece. Dr. Bouras graduated from the University of Medicine and Pharmacy in Romania. Subsequently, he pursued his orthopedic residency at the General Hospital Patras in Greece, and then moved to the UK for higher surgical training, which included fellowships at Southport, London, Oswestry, and Cardiff. Later, moved back to Patras, Greece as consultant orthopedic surgeon, and he completed his PhD at the University of Patras in Greece in January 2023. Dr. Bouras has several high-impact publications to his credit, especially in his chosen field of knee surgery. So today is my great honor to introduce you to Dr. Theodoros Bouras from Patras, Greece. Over to you, Theo.
Thank you very much for your kind words. Hi to everybody. My talk today has to do with graft selection in ACL reconstruction. The ACL ligament is the main stabilizer for the anterior translation of the tibia. It also contributes in rotational stability along with the medial meniscus. It consists 90% of collagen type 1, 10% of collagen type 3, has two bundles, the AM and the PL bundle. The AM bundle tensions in flexion, the PL in extension. The mean length is 30 to 35 millimeters and the mean diameter is about 11 millimeters. A little words about histology, because basically this is what we try to reproduce when we reconstruct the ACL. It's very important to know to understand the four distinct transition zones in the footprint of the ACL, with the ligament, the unmineralized fibrocartilage, the mineralized fibrocartilage, the so-called Sharpie fibers, and then the bone. A little words about history. The first who dealt with the cruciate ligaments was a Greek from ancient times called Galen of Pergamon, who gave the names, but until the 17th century, nothing more happened up to 1836, when the German scientists Wilhelm and Weber anatomically described the ACL. And then in 1895, Mayer Robson in Leeds did the first repair, followed by the first reconstruction using an ITB band in 1914 by Greco and Haygroves. Following that, big names that are still referred to our literature and our common practice, people like Elmsley, Triad, McIntosh, and Lemaire developed extra-articular procedures to deal with the insufficiency of the ACL without success, however, and consequently open procedures of the ACL reconstruction using a band of the patellar tendon were following these, and in the beginning of the 70s, the arthroscope came into our life. We reached today where several techniques and several grafts have been developed in order to deal with the ACL pathology. Talking about grafts, which is our main issue today, which type of grafts do we have? Two main categories are the autografts and the allografts. The autografts are the hamstring tendon, the bone patellar tendon, bone tendon, and the quadriceps tendon autografts with or without a bone block. Allografts is the BTB composites, Achilles tendon, the tibialis tendons, anterior and posterior, and the hamstrings, mainly the semi-T. And there are the synthetic grafts. We'll talk about these at the end. Comprehensively in this slide, we can see the advantages and disadvantages of autografts and allografts. The autografts are free to use. And being an autologous tissue, there is no fear of immune reaction or disease transmission. We expect long-term viability, low rates of infection, low failure rate, and of course, no ethical issues. Disadvantages is their limited availability, the increased operative time, the donor side morbidity and some functional impairment, some muscle weakness from the side the tendon is taken. On the other hand, the allografts, they have no donor side mobility, less postoperative time, better cosmetic appearance, large variety of sizes and graft sizes and shapes, but they are expensive. And most importantly, they can transmit disease. There are some concerns about their healing. The viability is still under discussion, and there are some ethical and religious concerns. Let's move to the autografts and start with the hamstrings. The hamstrings, along with the BTB, are one of the two most frequently used grafts for the reconstruction of the ACL. In these photos, you can see a typical harvesting procedure. Most surgeons harvest the semi-T and the gracilis in the mode you can see. There are some surgeons, according to the technique they use, they choose to take the semi-T alone and quadruple that and use it in some all-inside technique, and they have a very good graft to complete their ACL reconstruction. Advantages of the hamstrings is a reproducible technique with small incisions. We take autologous tissue. There is no anterior knee pain compared to BTB. Options to graft sizing, we triple, quadruple the tendons in order to get to the size we want. And most importantly, this is a strong graft. It's maximal load to failure, 4,500 newtons. Disadvantages, unpredictable graft size, because regardless we have to do the graft sizing, we still cannot calculate how long or how thick the graft is, even though there are some studies out there that can spread some light on that. Saphenous nerve injury, residual hamstring weakness, which is a big problem, especially when we have to deal with athletes. Windshield wiper effect, which in my view, depends on the technique that the surgeon uses, and elongation of the hamstrings graft in the long-term results. We can see some of that in later slides. Let's go to literature. From Kista 2013, this study reported 83 patients with a 10 years follow-up with a transtibial technique, ACL with hamstrings, 3 revisions, very good functional outcome with Lysol, Tegner, and AKDC. However, they did report 20% positive pivot shift, which was attributed to the transtibial technique, and 8% osteoarthritic changes to the knees. A very recent study that compared hamstrings graft versus hamstrings graft, 4 strands versus 5 strands, and 45 patients, and they found no statistical difference between the two groups, regardless that the accurate numbers were more attractive to the surgeon side when it came to 5 strands graft. And I say that because there is another study which comes from a big cohort, the Moon cohort, dates 10 years back, coming from the Ohio State University, Columbus, which studied 263 patients with a 2 years follow-up. And they found that the bigger the graft, the size of the graft in terms of diameters, the better the results. So for grafts over 8 millimeters, they had no revisions. And for every millimeter of increase in graft size, the subscales of the functional scores in Qs and subjective IKDC were improving accordingly. Let's move to the BTB autografts. The BTB is for many surgeons the gold standard. It knows renaissance at our times. At this slide, you can see the typical harvesting technique. This photo is coming from the publication of Dr. Laprade from the States. Typical insertion and harvesting of 1 centimeter graft along with bone plaques from inferior patellar pole and tibia tubercle. The advantages is, as I said, is for some surgeons, many surgeons, is the golden standard, is an autologous tissue. It gives the advantage of bone-to-bone healing within the tunnels. For some athletes, for many athletes, this gives the opportunity to return faster to their practice and subsequently to their sporting activities. This is also a strong graft with maximum load to failure of 2,600 newtons. There is no windshield wiper effect, and there is no residual hamstrings weakness. The disadvantages is the anterior knee pain, which can be up to 30%, which means 1 to 3 patients. This is the biggest problem with the BTB. There are some minimal invasive techniques of harvesting the BTBs, as the one we see in the photo, which makes the technique more demanding in terms of skills in order to harvest the graft properly. Patellar fracture and tendon rupture are there, but with very low percentage of complications, and tunnel mismatch is also a problem, but depends on surgeons' skills and experience. Moving into literature, for BTB, we see this study with a very long follow-up, 18 years. They studied 81 patients with very good functional outcome, results in Lysholm and Tegner score, but with lots of osteoarthritic changes over 50% of their cases. We have to say for this study that their initial cohort started with over 300 patients. They ended up at 18 years doing a final follow-up to 81 patients, and they never reported their failure rate in terms of revision. The BTB has become very popular in the States as well, and there are studies coming out reporting results of BTB allografts in patients over 50 years old with very good results. And then finally, this very recent review reported what is mostly known and what makes the BTB very popular, which gives better functional results, low revision rate, and the functional results are better in younger patients and faster return to pre-injury level activities. Quadriceps tendon autograft. Quads are becoming increasingly popular. More and more surgeons are using them as their primary graft in their routine ACL reconstruction. In these photos, you can see a typical quad harvesting. One is in a cadaver. Do not be frightened. I use this just to make easier to understand how the tendon is being harvested. The advantages is that it is a versatile graft. We can take half or full thickness with or without a bone block, with using minimal invasive techniques, as it was shown in the photos before. It can reduce the graft size variation, because with the specific harvesting tools, we can choose how much the length could be of the graft and how much the thickness of the graft can be. It is an autologous tissue, and it is proven that it has better biomechanical properties than the BTB. Disadvantages: donor side morbidity as any graft. However, most studies report that the donor side morbidity for quads is lower than the BTB. It has a steep learning curve. Younger surgeons who want to harvest a quad should have some experience along with surgeons that know how to do this. Quad weakness is also reported in very low percentages, patellar fracture as well. And the most important for me is that even though it gains more importance and it is very popular, more popularity, it has lackness of robust evidence in order to make this as a standard primary graft for ACL reconstruction. Going into literature, this study from 2020, 291 ACL reconstructions with 5 years follow-up. The authors here had 24 revisions, 10.7%, which is quite high. It's higher than the Danish registry. And the authors attributed that to the kind of the population they had, because most of them were athletes, and they proved that by referring to the Tegner score, that before injury, the Tegner score of the patients were 9, and most of them returned to 8, which is quite high. Good and excellent Leishholm and IKDC results, and a 5% anterior knee pain. And this study, very recent study as well, the authors used a press-fit quadriceps tendon patellar bone autograft. They had a 7.5 years follow-up with 6 patients, 9% re-rupture, and they found good results as well, as expected. And the interesting thing in this study is that they compared the 2 legs, the operated leg and the other leg, using single leg triple hop and KT1000 for stability, and they found 98 and 89% similar results, and in almost 80% of the patients the pivot shift was normal. I close quads with these 2 studies because these 2 studies are talking in favor of the quad tendon. Big systematic review with 14 studies, 1,154 ACL reconstructions, excellent results, and the International Quadriceps Tendon Interest Group, including in the authorship Christian Fink, who is one of the pioneers of quads tendon. He has patented one of his own harvesting tools. And they both refer to quads tendon, use it now, use it often. We move to allografts. I'm not going to say any more about advantages and disadvantages. We talked about that in the beginning, but I am going to discuss about indications, and these are very, very important for people to understand. The allografts are mostly indicated for patients older than 40 years old. Patients that had surgery in the past and they need to be revised. They had prior harvest from donor sites. They have multiple ligament knee injuries, so we need more graft to finish the operation, and the patient's preference. In the States, there are a lot of surgeons that they use allograft as a standard, as routine, but always the patient has to be informed about the immunization and preservation of the allograft. In terms of immunization, there are the irradiated, non-irradiated, the chemically immunized grafts, and then in terms of preservation, deep frozen and fresh frozen grafts, allografts. It is clearly established in the literature that fresh frozen, non-irradiated grafts have better results. Now, there is a bunch of literature in terms of allografts, and all of them say very beautiful things about allografts, but they all conclude into that allografts are a viable option for ACL reconstruction. There are comparable results with autografts. However, when it comes to younger patients, the failure rate is increasing rapidly, and we can see that in this study from 2015, study in the American Journal of Sports Medicine. The difference is very, very significant. Now let's talk about synthetic and or artificial grafts. The advent of artificial ligaments dates back to the beginning of the 20th century, when silver and stainless wires, nylon and silk strings, and various synthetic fibers were used to create artificial grafts. However, the unsatisfactory results and the high rate of early ruptures confined these initial attempts to the stage of animal experience, and these materials were never adopted in clinical trials. In the 70s, the interest for synthetic grafts led to introduction as substitutes for biological human tissue. The increased appeal of these supports resulted in the commercialization of products such as the Proplast ligaments, made of Teflon and carbon, and Polyflex ligament made of polypropylene. These had catastrophic results as well, not only in terms of failure rate, but in terms of wear rate and synovitis in the knee. For that, the synthetic grafts were abandoned in the ACL reconstruction world. However, there is a third generation synthetic grafts, such as the last ligaments made of polyethylene terephthalate, and the literature is now starting to develop in favor of synthetic grafts. And we can see some of this literature coming out. This study from 2017 compares mainly BTB with LAS, giving short and mid-term comparable results. Another study, it's a bit older, reporting reconstruction of ACL with LAS ligament, showing very good results in terms of functional scores, a big number of patients with only 3 ruptures and 1 synovitis. 93% of patients were very satisfied or satisfied with the outcome. And then there is another study, very recent, 2021, comparing 2 different types of allografts, the neoligaments and the fiber tape. We knee surgeons are familiar with the fiber tape. We use it for internal bracing and for various repairs of the ACL. In this study, the authors reported 2 different groups, one with neoligament, one with fiber tape. The results in both groups were very good in terms of function, and there was no statistical significant difference between them. And just to finish with the synthetic grafts, there is lots of experimental studies going on, and this part of the science is still developing. In this study, the authors used wet and dry electrospinning with a biodegradable elastomer in order to create a graft, and they compared wet, dry, dry polycaprolacton artificial graft and autologous flexor digitorum longus tendon graft, and they found that in the wet PEUU, the in vivo tensile strength of the wet graft had significantly increased in the first 8 weeks. So there is lots to see from that coming up, and I'll stop here with the synthetic grafts. For me, the most important talk part of this talk is the comparative literature, and here we go. Recent meta-analysis comparing hamstrings versus patella tendon BTB, including over 47,000 patients, reporting those short and mid-term results, found similar results. Not significant, not statistical significant different, even though the absolute numbers were better for the BTB. Another meta-analysis from 2019, including quadriceps tendon and comparing it with BTB and hamstrings, found comparable results between the 3 autografts, but better outcome, functional outcome between quad and hamstrings, and better donor side mobility between quad and BTB. In terms of pre-injury activity levels. This study coming out from New Zealand 2021 found that the BTB in the first and the second year following the operation had significantly better results. And you can see the numbers in the slide. And the results were even better when the patient was male and younger in age. Another meta-analysis coming from Boston, Massachusetts, reporting hamstrings versus BTB, found similar re-rupture rate, similar return to pre-injury levels, but overall higher return to sports or to pre-injury levels, activity levels for all the patients. And we're talking about over 2,000 athletes. More studies, recent studies, 2022 American Journal of Sports Medicine, talking about hamstrings, BTB, and quadriceps tendon. Again, we see comparable results in survival, in function, and the well-known lower quadriceps tendon donor site mobility. In terms of yearly failure rate, there was no significant difference, not only between the autografts, but between the autografts and the allografts themselves, which is a bit weird, but the actual numbers show that the allografts had bigger rate. However, there was no significant difference. Further studies, recent studies, allografts versus autografts tendons, 10 years follow-up, lysosomes and IKDC, similar functional results, no complication in the allografts group. And then allograft versus autograft in a very recent study found less postoperative pain, smaller complications, shorter time to return to work, better cosmetic effect, and higher cost for the allografts. These are the results, the preliminary results of our series. We small numbers yet, but we are working on that. And we have reported mainly results for a non-athletic population, people that live and work within the city, or in the suburban area of the city, farmers, delivery boys, people that work in logistics, and they injured themselves during transportation or at the work. The most important thing, I'm not going to tire you with the numbers. For us, the most important thing is that all of the patients at 3 months' time, they had fully returned to their working duties. We have now a good number of athletes as well, and we hope in the future to be able to publish both series and compare them between them. In my take-home message, what I would say is that the graft choice depends on the patient's characteristics, needs, and preference, as long as he is fully informed of what he's going to take. Also depending on surgeon skills and experience. So the surgeon should choose a technique that he's well prepared and well trained to do. In terms of activities of the patient, a contact pivot sport, athlete, or even a non-athlete, a recreational athlete, BTB is ahead and should be used. Quadriceps tendon grafts are very good grafts, very strong grafts. They become more and more popular, but they still do not have the robust evidence of becoming the golden standard. Allografts are a good option for older patients or in multi-leg situation, and we should always use non-irradiated fresh frozen grafts, and synthetic grafts are not an option for routine ACL reconstruction just as yet. Thank you very much.
Thank you, Theo, for this detailed presentation. Theo, you can stop sharing actually. Yeah, Theo, you can stop sharing. Yeah, thank you, Theo, for this detailed presentation. And just before I hand over to Law, I just want to ask, have you tried using the peroneus tendons ligamentous in your knee?
No, I haven't, even though I have them on my shelf and I have specifically requested for them, but I haven't yet. And the reason is that I deal with younger patients. I did a young girl, she's a football player, 23 years old. So I used her own hamstrings and she had a very, very good result. The discussion there would be, should I have used a BTB or not? And there are studies saying that, especially in girls, if you use a BTB, the anterior knee pain is something that bothers them very, very much, females versus male. There is also discussion when you're doing younger patients, even more skeletally immature. When you do an ACL reconstruction, should you use an extraarticular tenodesis as well to augment your ACL? That's a good discussion to do. I personally do extraarticular tenodesis in my primary ACLs only when the Baton score is higher or I have an increased posterior tibial slope. In that case, I would, or have an explosive pivot shift. If not, then I will go straight for an ACL reconstruction, and that's it.
Thank you, Theo. We also joined by Loy. Loy, I think, is an orthopedic sports surgeon based in Dubai. Loy, your questions to Dr. Flores, please.
Thanks, Theo, for the amazing review for all these ACL grafts. If you notice, to all of these grafts, the three most popular grafts, they have similar outcome. But
yes,
in reality,
they do.
Yeah, but in reality, the major revisions done for the hamstrings.
Yes. The reason for that is that there are studies in the long term that they report elongation of the hamstrings graft, and that is the problem. So the quality of the hamstrings of the graft is starting to degrade as year passes by. And that is one reason for the failure of the hamstrings graft. But in short and mid-term results, up to 10 years, you can find similar results.
Exactly. So the question now, would you add internal brace when you do harvest this hamstrings graft? Do you think internal brace will protect them from this early rupture rate?
That is a good question. I watched this question in an ESCA webinar, and all the authors said, do not use fiber tape in an ACL graft. I have personally done this only once when my graft was not of good quality. I had a 7.5 and I wasn't happy for a 7.5 graft. So I augmented it with a fiber tape.
Yeah, this is a good point. Yeah, when you have a, let's say a 7.5 or even 7 millimeter graft, what choices do you have to augment your graft? Maybe you can give us a tip on how to augment or what to use to augment your graft.
As I said, I will use fiber tape to do that. I prefer not to be honest. I try to have a good quality graft. In that patient, if I knew that his hamstrings would be so lean, even though I tried to triple the semi-T, still the graft was poor in terms of thickness. So I had to unprep the patient, reprep the other leg to take some more hamstrings, or change the graft and take BTB, so change my technique, which the patient was not consented for any of these. So I had to do something on the table at this moment. So I said, just get me fiber tape. And I had the fiber tape. The graft was stronger. I had around 8 millimeters of graft. So I was happy with that. The patient is now 3 months down the line. He's doing very well, good range of motion, stable knee. So we'll see what happens when he returns back to sports.
Awesome. That's exactly that's now I'm shifted, to be honest. This is the downside of using hamstrings as a graft, because the size is sometimes is unpredictable. Anyhow, and sometimes it's tricky to get because my aim is above 8 or minimum 9, to be honest. It's 9 to 10. This is my graft size. So I'll switch now to use the quads tendon, which I believe this is if you read about the go deep into the quads tendon, this is the highest concentration of collagen type 1 in this type of graft. And the healing rate is faster. I haven't seen any weakness, quads weakness, and they go faster back to their sports or daily activities. Do
you suture the quad after you take the graft? Do you suture?
Sure, yeah, I do. Exactly. I sutured that. I learned that during my fellowship in Canada. I used the scorpion to suture or suture passa to suture the quads tendon, and like a running suture, and just to close it. And this is I keep the incision open to once I start scoping the knee. So this will give me an idea if there's an extravasation flow. That gives me an idea if I took a full thickness graft or not. Even though if you took a full thickness graft, this is not so bad, and you will still have a good choice, and the graft quality is really good. And you need at least 6-7 centimeter of the graft. We can easily acquire. I think the quadriceps graft is promising, and the number of grafts is now, especially in Dubai or where I used to work in Germany. This is the number of using this grafts is becoming more and more. How about do you think that developing a cyclops lesion is more common in certain types of grafts, such as hamstrings, or do you think the studies there are enough studies to show the cause of the cyclops until now?
I'm not sure about that. I think that cyclops lesion is a multifactorial thing. It has to do with the graft, but it has to do with surgical technique. It has to do with the immune response of the patient as well. And each patient has different immune responses. I've done over the last 4-5 months about 50 ACLs, and I had one cyclops lesion in a patient who did not cope with his physical therapy as he should have, because I talked with a physiotherapist and I said, why is this patient doesn't do well? And she said, man, he's not coming for physiotherapy. He comes once in a while. So maybe that was the reason that the cyclops lesion developed. He had lots of arthrofibrosis as well. But I think that hamstrings do play a role, and I'm not sure about what the literature says about the cyclops in hamstrings, but I haven't seen any literature talking about high cyclops in BTB or quads.
That's true. So as a TO, what's your first choice in graft?
Hamstrings.
Okay.
Yes. Yeah. Hamstrings.
Once hamstrings, always hamstrings. And for revisions?
Revisions is BTB. If the patient is older, I might use an allograft. And I always do a modified lamella, an extraarticular tenodesis for my revisions.
Exactly. So this is a good point to mention that. Do you do the LAT first, then you go to your ACL reconstruction, or vice versa? So
no. From my primary to my revision surgeries, I finish intraarticular what I have to do, and then I go extraarticular.
Exactly. This is the message here. It's just to release the tourniquet. You finish the intraarticular work, you do your ACL reconstruction, you can release the tourniquet and do the extraarticular work by doing lamella and so on.
Yes.
This is the trick here.
The only thing with the modified lamella is you have to be careful with tunnel convergence. Some people use anchors. I do a tunnel. I just turn my drill. Interference screw 30 degrees. Superiorly, and an angle of this degrees, and then I have no big problem, to be honest.
Awesome. Thanks to you, and wish meet you soon when one of the ISCA
Yeah. Any more
conferences.
questions, Lloyd?
I think that's it for the
Okay.
for tonight.
Thank you, Theo, for this detailed presentation. And that's all the
Thank you.
questions that we have for this session. I'm sure this lecture is going to benefit a lot of people all over the world. And looking forward for another one in future, Theo.
Excellent. Of course. Nice meeting you.